Do you see something that told you that recording started? Now we have. Welcome, everyone. We're so happy to have you back to BayCare Presents. This is our monthly series where we bring experts to you so we can help increase your knowledge about all things health and well-being and just give you some tools so that you can make the better choices to navigate your own health and well-being. We are really excited today to have Dina with us. She is a licensed certified genetic counselor, and she's been with BayCare since 2017. And she was actually our first certified genetic counselor for BayCare, and she has just been working diligently to help build our cancer genetic program. She completed her bachelor's in biomedical science at the University of South Florida and has her master's in human genetic and genetic counseling, from Emory University School of Medicine. And she works very hard to educate healthcare providers to understand and recognize the signs of hereditary cancer symptoms. This is a way for them to be able to identify those high-risk individuals and allow for early detection and prevention. And that's cancer. That's key when we are trying to be able to have better health outcomes for all of our individuals. So I'm really excited to have her here today. She's a native Floridian, loves the sun, sand, and the beaches, and of course is always using her sunscreen to keep her safe. But she is here to share with us today about hereditary colon cancer and getting your rear in gear. So I am going to turn this over to Dina and let her share this information with us. Thank you.
Thank you so much, Jean Marie, for inviting me to talk. I'm excited to share some information about colorectal cancer, which isn't as exciting or talked about as breast cancer, for instance, but it still has plenty of importance in terms of prevention and what we can do in terms of screening to inform individuals about their risks and how to promote better health outcomes in themselves and potentially their family members. So just some of the topics we'll be covering today. We'll talk about what colon cancer is, and I'll use colon and colorectal interchangeably. So they're referring to the same thing in terms of this discussion and presentation. We'll talk about risk factors, signs and symptoms of colorectal cancer. We'll talk about hereditary colorectal cancer, as well as what types of screening and management we have for the detection, prevention, and treatment of colorectal cancer. So colorectal cancer is the abnormal growth of cells within the colon or rectum, and we all have lining in our colon and rectum. And sometimes within the lining and the cells within this lining, the cells can grow out of control and form a tumor. Sometimes the tumor can invade nearby tissues or nearby organs. And usually these growths and these tumors begin actually as a polyp. And when we think about signs and symptoms of colorectal cancer, a lot of them overlap with just kind of things people experience on the day-to-day or sporadically, and there may very well be no underlying cancer for some of these symptoms. So some of the symptoms we'll see perhaps are blood and stool, or someone who may experience constipation, diarrhea, unintentional weight loss. And when these symptoms become prolonged or frequent or experienced over perhaps a week, 2 weeks, they should certainly be discussed with a healthcare provider to determine if there is any malignant or cancer that's causing these symptoms. Something to really think about is a lot of times colon cancer is actually diagnosed in an individual who's not experiencing any of these symptoms. So typically, a person who presents with colon cancer, they're found on a screening colonoscopy. There's no symptoms they're experiencing, it's just they're going in for their routine screening for colon cancer, and cancer is actually detected. Colon Colon cancer is actually the second most common cancer that's experienced by both men and women. So yes, breast cancer in females is very common, prostate cancer in males, but lung cancer is the most common cancer experienced in men and women. And then that's followed by colorectal cancer. And in 2022, there was about 151,000 new colorectal cancers in the United States and about 52,000 deaths from colorectal cancer in the United States. And if we think about our lifetime risks for colorectal cancer, about 1 in 20 individuals, or 4% of individuals, will develop colorectal cancer over their lifetime. There are some uncontrollable risk factors people have for colorectal cancer. This includes age. So as we age, our risk for cancer increases. That's why we typically will see older individuals developing cancer, whether it's colorectal cancer, whether it's breast cancer, and other cancers like prostate, lung. Typically, we see folks over the age of 60 diagnosed with these cancers. Uncontrollable risk factors also include your family history, or if you have a hereditary condition that increases the risk for colorectal cancer. A personal history of irritable bowel syndrome, inflammatory bowel disease, Crohn's disease, all of these inflammatory conditions can increase one's risk to develop colorectal cancer. And certain racial or ethnic backgrounds, there's an increased incidence of colorectal cancer as well. Some controllable risk factors, so what we can actually perhaps change to whether it's increase or decrease our colorectal cancer risk, what we're eating. So diets that are high in fiber actually reduce the risk for colorectal cancer. A diet where one consumes less red meat or less processed meat, maintaining a healthy weight, avoiding type 2 diabetes from developing if possible, and then reducing our alcohol consumption. These can all reduce our risk for colorectal cancer. And something to also acknowledge is someone can live a very healthy lifestyle and do everything right in terms of their diet, their exercise, and activity level. And they still can go on to develop colorectal cancer. So just keeping that in mind as well. To acclimate you just with the colon and the structure of the colon, we have the ascending colon on the left side of this image. And then we have the transverse colon, the descending colon, sigmoid colon, and then the rectum. And the ascending colon on the left side attaches to our small bowel. So usually we'll see the small bowel, and then the large bowel is the colon and the rectum. And colonoscopies are a way we can actually visualize inside of the colon. And there are typically polyps, which can be sometimes identified during a colonoscopy and removed during a colonoscopy. And this image on the left, the right side of the screen is showing the appearance of polyps during a colonoscopy. There can be flat polyps. These are not very common. The most common polyp is a sessile polyp, which you'll see as a raised area above the lining. And then there can also be pedunculated polyps, which means that the polyp actually has a stalk and then kind of a enlargement at the end of that stalk. When we think about pathology of polyps, this is when a polyp is actually kind of taken, sliced up, put under a microscope for us to look at in more depth. And there are various types, and of these types, some of them can be associated with cancer risk. The vast majority of adenomatous polyps are tubular adenomas, and only about 5% of tubular adenomas develop into a cancer. Tubulovillous adenomas account for about 15% of adenomas and have about a 20% cancer risk. And villous adenomas make up about 10% of adenomatous polyps and have about a 40% risk for colorectal cancer. There's also sessile serrated adenomas, and then some polyps that do not have a cancer risk associated, such as hyperplastic and inflammatory polyps. And the point of this is just to familiarize you with, if you do get a colonoscopy report and a pathology report, some of the terms may be unfamiliar, so hopefully this kind of gets you a bit more familiar with some of the terms that are used and what's being done in terms of what we look at under a microscope to determine if someone should be repeating colonoscopies more frequently, less frequently, what their cancer risks are, etc. So we're going to get into talking a bit more about how we screen for colorectal cancer and the medical management available to reduce one's risk for colorectal cancer or manage a heavy polyp burden. So a colonoscopy is the gold standard in terms of colorectal cancer screening and prevention. Colonoscopies are performed by the insertion of a flexible long tube into the rectum, and this tube has a tiny camera that can allow for the visualization of polyps or other disease such as Crohn's disease, IBS, etc. And there can also be a mechanism to allow for the removal of polyps during the colonoscopy. And this is visualized in this image right here. The reasons why colonoscopy is done, again, colorectal detection for cancer as well as prevention of colorectal cancer. It can be looking for what's causing certain signs and symptoms an individual may be experiencing, such as rectal bleeding or blood in the stool, diarrhea, constipation, etc. Treatment of some of these issues. And depending on the number of polyps an individual has, if any, the size of those polyps, the type of those polyps, as well as the family history of colorectal cancer, this will dictate how often they should be undergoing colonoscopies. So typically the gastroenterologist that performs a colonoscopy, or the colorectal surgeon in some cases, they'll take a look at what's found during colonoscopy and then make recommendations for repeat based on those findings. So sometimes an individual can actually have too many colon polyps to be removed during a colonoscopy. And in these cases, a resection may actually be warranted. And a resection involves the removal of a portion of the colon and then the connection of the adjacent colon pieces to allow for a continuous flow of excrement. So this really occurs when the number of polyps cannot be removed, perhaps due to fear of missing polyps or a fear of some of the polyps being too large for removal without leaving any cancer cells behind potentially, or whatnot. So this is done to just promote and allow for, and I should have said precancerous cells earlier. So this is really just to promote and allow for the removal of all polyps in a high-risk individual. And there is another screening tool that was developed within the last 10 years, and it's called Cologuard. And Cologuard is basically a stool test. And this screen, the Cologuard screen, is pretty convenient. I did not mention previously that with colonoscopies, one does have to do prep. So going back to colonoscopies briefly, because we're during a colonoscopy, inserting a scope in the colon, it has to be clean. So the day before a colonoscopy, an individual will drink a liquid that allows for all of the waste in the colon to be passed through or evacuated, as some would say. So this allows the colonoscopy and the scope to pass cleanly. There be there will be no blockages, hopefully, and the colon can be visualized adequately. And that process of going to the bathroom, removing all the waste it can be an arduous process. It is not the most pleasant, but it does allow the colonoscopy to be done thoroughly. With Cologuard, no prep is necessary. An individual will be sent a kit in the mail, and the kit can be used for their stool collection. So the individual will collect a sample of their stool and then send this sample back to the lab. And the lab will analyze the stool sample for DNA markers that indicate there could potentially be cancer in the colon. And Cologuard is wonderful in terms of the detection of colorectal cancer, but especially advanced stages of colorectal cancer. However, it does not detect necessarily precancerous polyps with a very good sensitivity. So Cologuard can be used and is recommended for individuals who, beginning at age 45, who are at average risk for colorectal cancer. So we talked about, about a 4% lifetime risk for colorectal cancer in the average person. However, if an individual has a family history of colorectal cancer, a personal history of colorectal cancer or colon polyps, IBS, it's not recommended for any high-risk individuals. And it's certainly not a replacement for a diagnostic colonoscopy when someone is experiencing symptoms such as blood in the stool, extended periods of constipation, diarrhea, etc. So again, just to go over our screening recommendations for colorectal cancer. For an average risk individual, Cologuard can be considered and will be done every 1 to 3 years. For colonoscopies can also be done in the average risk individual beginning at age 45, and the frequency for repeating a colonoscopy will depend on the findings of their first screening colonoscopy at age 45. High-risk individuals, such as people with IBS, a personal history of colorectal cancer or colorectal polyps, a family history of colorectal cancer, or a hereditary predisposition to colorectal cancer, we would begin colonoscopies at the time symptoms may be experienced, and colonoscopies will be done at a frequency dictated by what's found during colonoscopy, or even if someone has a family history of colorectal cancer, we may begin earlier than age 45. We typically will say, okay, if a person has a first-degree relative, so a brother with colorectal cancer that was diagnosed at 40, we should start that individual at age 30, 10 years earlier or younger than the youngest diagnosis of colorectal cancer in the family. And regular screenings with colonoscopies can prevent colorectal cancer by the removal of precancerous polyps. So that's why it's so important for folks who are not average risk, who have a higher risk of colorectal cancer, to undergo these screening colonoscopies. So what is hereditary cancer? Hereditary cancer is cancer that is caused by a gene mutation that is being passed down in the family from one generation to the next. And we'll go over a lot of these definitions shortly. But if we were to take all colorectal cancer, only about 10% of them, and I should say probably 5 to 10% of them, are hereditary in nature, meaning due to a hereditary cause or a gene mutation being passed down in the family. The vast majority of colorectal cancer is due to chance, due to environment, lifestyle, age, etc. So what is DNA? DNA stands for deoxyribonucleic acid. And DNA is the instructions that tell our body how to work and grow and function. And DNA is contained in each of the cells of the body, and we have trillions of cells in our body. All of our body is made up of cells, whether it's our skin, our hearts, our muscles, etc. We all inherit half of our DNA from our mother, half of our DNA from our father. And each of our children, therefore, inherits half of our DNA and then half of their father's DNA. So if a family member has a gene mutation, so if a mother, for instance, has a gene mutation that increases the risk for colorectal cancer, then each of their children would have a 50% chance of having that same gene mutation, because remember, each child is half their mother and half their father, DNA-wise. And what are genes? So genes are the parts of our DNA that have a specific job. Some of our genes code for what we look like, so our eye color, our hair color, how tall we are. Other genes protect us from certain diseases, including cancer. This image is humorous. If there were a gene that indicated that someone has a higher likelihood to believe that all bags should be carry-on bags, that would be a gene I definitely would have. But in general, we all have the same genes. It's just sometimes there can be differences in these genes that make us unique, or there can even be mistakes in these genes that cause a disease to manifest, or one to have an increased likelihood to develop a disease. And some of the features of a colorectal cancer that make us concerned that it could be due to an underlying hereditary cause, perhaps an individual is young when they are diagnosed with colorectal cancer. And young typically indicates that an individual is under the age of 50. Perhaps an individual has multiple primary colorectal cancers, whether at the same time or over their lifetime. Perhaps there's a particular family history of multiple people in the family diagnosed with colorectal or related cancers. And there's a note on the bottom of the slide that indicates some of the related cancers, such as uterine, stomach, intestinal, ovarian, etc. Also, there are tumor studies. So when a colon cancer is biopsied, there can be studies performed on the cancer cells that indicate there's a higher likelihood that that cancer arose due to an underlying hereditary condition. So genetic testing is a way that we can actually detect some of these gene mutations that lead to an increased colorectal cancer risk, or just an increased cancer risk. And genetic testing allows us to look at the DNA in a cell and focus on genes that should be protecting us against cancer, to see if they're working. And typically, these cancer protection genes work in a way that creates a barrier that doesn't allow cancer to develop. They provide instructions that allow our cells to be robust and remain cancer-free. And when these cancer protection genes aren't working appropriately, when they have mutations or mistakes that don't allow the instructions to promote these barriers from stopping cancer to develop, that's when we'll see an increased cancer risk. A lot of times, so in the vast majority of people who develop cancer, these mutations are acquired over their lifetime. So whenever cancer develops, there are mutations in those cancer cells, but those mutations are confined to the cancer cells. And again, these typically arise over one's lifetime. They're somatic in nature, is the technical term. However, when an individual is born with a mutation in a particular gene, that mutation is present in every cell of their body. They're already at a disadvantage in terms of their ability to prevent cancer from forming. These are known as germline mutations. what we're talking about today, the type of genetic testing we're discussing is looking for these germline genetic mutations an individual is born with that are present in every cell of their body. There are genetic tests that look for somatic or acquired mutations, and these typically are done in the therapeutic setting to help guide treatment of an individual who's diagnosed with a particular cancer. These tests can also be used to determine the risk of recurrence or a spread of a particular cancer. But again, we're talking about germline genetic testing. So looking at DNA and genes an individual is born with to potentially determine if there's a mistake in one of those genes that increases the risk that an individual will develop cancer. So this slide is showing just some of the genes that are related to hereditary colorectal cancer, and these are some of the more well-known genes. These are, again, just some. There are many more genes related to hereditary forms of colorectal cancer, but genetic testing nowadays really is comprehensive. So most of the patients I see in practice, when I order genetic testing for them, their tests include upwards of 70 or 80 genes related to a variety of cancers, not only colorectal. So we can get a good idea of how we can be proactive across their health and in terms of preventing whether it's colorectal, or breast, or ovarian, or uterine cancers by more vigilant screening or certain preventative surgeries. So we're just going to get into one of the hereditary conditions that increases colorectal cancer risk. And this condition is the most common cause of hereditary forms of colon cancer. And it's called Lynch syndrome. And I may refer to it moving forward as just LS. So again, LS is the most common hereditary cause of colorectal cancer. About 1 in 279 individuals in the US have a genetic mutation in a gene associated with this condition. And what we typically see occurring for the LS genes, they're all responsible for a process called mismatch repair during cell replication. So when our cells need to produce more cells, their DNA needs to be duplicated or replicated. So what the mismatch repair genes do, or the Lynch syndrome genes, they make sure that the DNA that's duplicated is identical to the original copy. So if there's any differences, these Lynch genes are responsible for correcting any errors that occurred during the replication process. So you can imagine if these Lynch genes aren't able to work properly in an individual, that individual would more easily accumulate errors in their DNA because the mechanism to correct and identify those errors isn't working as well in that individual compared to a person without Lynch syndrome. So LS is caused by a mutation in any one of the 5 genes, MLH1, MSH2, MSH6, TMS2, or EpCAM, listed on the right-hand side of this slide. And each of these genes has a different set of cancer risks. They're associated with the same cancers, but the degree of risk is different depending on which of these genes has a mutation. And that really highlights the importance of genetic counseling to really thoroughly go over what implications and management and screening are recommended depending on if a mutation is identified in any of these genes in an individual. So for Lynch syndrome, the lifetime colorectal cancer risk is up to 61% for some of the higher risk LS genes, and the endometrial or uterine cancer risk is up to 57%. I realize this is a busy slide, and this slide is just really meant to show the global impact LS has on an individual in terms of the elevation of cancer risks and what organs may be involved. So we've talked about colon and uterine, which are certainly the highest degree of elevation of risk for people with LS, but also ovarian cancer risk is up to 38%. Stomach cancer up to 9%, kidney or ureter cancer up to 28%. So when an individual is identified as having this condition, there are very clear screening and management recommendations to allow for the either early detection or prevention of some of these cancers. So for instance, if we know an individual has LS, we would start colonoscopies as early as 20 to 25 and repeat them every 1 to 2 years. And if a person has an active diagnosis of colorectal cancer, a larger surgical approach may be considered for the removal of that colorectal cancer and potentially removal of the remaining colon to reduce the risk of a second primary colorectal cancer. So we know that people with LS have an up to 50% risk to develop another colon cancer if they're already diagnosed with colorectal cancer. So some surgeons may discuss the option of a complete colectomy just versus a partial colectomy. Another thing we would talk about potentially is taking a high dose daily aspirin to reduce the risk of colorectal cancer in individuals with LS. To address the uterine cancer risk that's elevated, we would talk about removal of the uterus. Typically, this is done after age 40 for females or once they're done having children. And by doing this, the risk for uterine cancer is reduced by over 95%. We never say 100% because there can always be some cells remaining from the uterus. Ovarian cancer is similar. When a woman is done having children after age 40, we would consider removal of the ovaries and fallopian tubes for some of the LS genes that are higher risk ovarian cancer genes. There are other considerations for screening in individuals with LS depending on the family history of cancer. So if there's a family history of pancreatic cancer, we would consider pancreatic cancer screening with an MRI of the pancreas or an endoscopic ultrasound. Annual urine analysis can be considered as well for folks with a history of kidney or urothelial cancers in their family. There can be some benign skin findings in LS known as sebaceous carcinomas, and these or adenomas, and these can be addressed via an annual dermatologic exam, which I recommend for everybody in Florida anyways, especially with all the sun exposure for the early detection of any types of skin neoplasms or cancers. And then to address the gastric and small bowel cancer risk, we could do endoscopies every 2 to 4 years, etc. So I'm going to go through just a couple of cases to really highlight the differences in how families may present with LS depending on the gene that has a mutation in it. So to acquaint you with how we look at this image and how we read this image, this is known as a pedigree. It's a family tree. And men in this family tree are squares, women are circles, and a line through someone indicates that they have passed away. This arrow indicates that this individual is my patient. And he came in to me following some screening that was done on his tumor that showed that his colon cancer may have arisen due to an underlying hereditary condition, Lynch syndrome, which we've been discussing. And this man also had a history of some sebaceous adenomas, prostate cancer, and he was age 70 when he came into clinic, and all of his diagnoses were in the late 60s. So we had began taking the family history and going through it, and it was quite striking. He had multiple siblings diagnosed with colon cancer in their 40s, some of them succumbing to cancer and dying from the disease in their 40s. And then two of his siblings dying from cancer as well in their 60s, both of whom had colon cancer. His father, if we come up, we can see that this individual has a father who passed from colon cancer at age 84. He had many aunts and uncles on both sides of the family, and he didn't really have a lot of information about them. They lived in Puerto Rico. There wasn't a lot of communication, so there may have been some information we were missing in terms of cancer diagnoses. He did end up undergoing genetic testing, and he tested positive for a mutation in the MSH2 gene, which is a high-risk LS gene, and it provides a really clear explanation for what's going on in his siblings, why they were diagnosed with colon cancer in their 40s or 60s in one sister. And it explains his diagnoses with colon cancer and the sebaceous skin neoplasms and potentially the prostate cancer. There's some studies that indicate people with LS do have an elevated risk for prostate cancer. So at this point, you know, we've identified the cause of his cancers. We know now what potentially caused his siblings' cancers. And what's striking about this is if we had known 20 years prior that one of his siblings had this condition, I would believe that many of them would not have succumbed to cancer because we would have been doing colonoscopies every 1 to 2 years beginning at an earlier age. We would have caught cancer at an earlier stage when it's more treatable. His kids now have undergone genetic testing. Both of them are actually negative for the mutation. He has an MSH2, so they do not have Lynch syndrome, which is very reassuring. But this knowledge of what is causing the cancer in the family is not only going to allow this patient to be more proactive with his health, but also now his children who've undergone genetic testing and potentially his nephews and nieces. And hopefully we can prevent another colorectal cancer or some of the other cancers that are seen with LS in the patient or his family members moving forward. And we'll take a look at just one more case. And again, here's my patient. This arrow is pointing to her. And I actually remember her extremely well. I believe I saw her in my first or second year at BayCare, a 30-year-old female who actually has trisomy 21, also known as Down syndrome. So she came to the appointment with her mother, her father, her sister, her brother. And she was identified not only based on her young age of diagnosis with colon cancer, age 30, but also some studies that were done on her tumor that indicated the tumor may have been due to an underlying hereditary cause, Lynch syndrome. And we do that screen on all of our colorectal cancers at BayCare. We screen them all for Lynch syndrome, as well as uterine cancers. We do the same thing, and small bowel cancers. So this individual came to clinic with her family, and we did end up ordering some genetic testing, which showed a PMS2 mutation. And PMS2 is one of the lower risk Lynch syndrome genes. And as you can see, there's not really the striking family history. We did end up testing her siblings. Both of them were negative for this mutation. Her mother ended up testing positive, but you could see her mother does not have a history of any of the associated LS cancers, such as colon, uterine, small bowel, etc. Her mother, for other reasons, had a complete hysterectomy in her 40s. So this actually may have hidden a potential uterine or ovarian cancer diagnosis. We always ask about the presence or absence of the ovaries and uterus and first-degree relatives of a patient coming in to see if we may be missing a potential diagnosis just because that person doesn't have those organs. And this patient, she ended up undergoing a complete hysterectomy probably last year, so she's about 35 now or so. And she's continuing with her monitoring and follow-up for her colorectal cancer, which was pretty advanced at the time of diagnosis, unfortunately. In summary, some things to take away from this talk. Most people who are diagnosed with colorectal cancer are asymptomatic. They're going in for their screening colonoscopy, and colorectal cancer is identified at that time. Most colorectal cancers are sporadic, meaning due to chance. Only 5 to 10% are hereditary. And Lynch syndrome was the condition we talked about that's the most common cause of hereditary colorectal cancer, but there are many others. It's really important to discuss your personal or family history of colorectal cancer, colorectal polyps with your providers, so they can determine, and you can even help determine, if your personal or family history perhaps warrant genetic counseling to discuss options for genetic testing and if it's right for you. Genetic testing is a way we can identify any hereditary predisposition to colorectal cancer as well as other cancers, and to take a more proactive approach to monitoring and preventing cancers from developing in an individual and potentially their family members. They can significantly impact one's quality of life, one's health, and the quality of life among family members as well. Colonoscopies allow for the removal of precancerous polyps and prevention of colorectal cancer, and Cologuard may be considered for individuals at average risk for the development of colorectal cancer, but is not appropriate for high-risk individuals. The earlier the stage of colorectal cancer, when it's detected, the better the prognosis for that individual. So sometimes surgeries can actually be curative, and an individual may not need adjuvant chemotherapy or radiation therapy or immunotherapies. So being sure to discuss any signs and symptoms potentially of colorectal cancer with your providers, undergoing routine screening, whether it's through colonoscopies or Cologuard, depending on if you're average versus high risk, really will help promote the best health outcomes for you, and potentially educate and inform healthcare providers if there's any other cancer risks that need to be monitored based on genetic test results if genetic testing is indicated. Okay, I'm all set, so if there's any questions.
Thank you so much. That was wonderful. And as you can see on the screen here, if anyone needs to get a hold of you, this is how they can do that, because this is such an important topic. And I think, as you said in the beginning, people don't really want to talk about, basically your colon all the time. It's kind of one of those quiet subjects. So it's kind of nice that you made it a little bit more approachable and gave us such great information here and opened up our eyes to some different paths that people may not be taking and some conversations they need to be having with their physicians. So I just want to thank you so much for being here today. And we're going to turn off the recording and then turn it over to questions. So thank you so much.